Alrighty, good evening or good afternoon to everyone from across Canada or abroad who's tuning in today. I'm just going to give everybody a couple seconds to begin joining the webinar. Lovely, lovely, lovely. We're seeing tons of people coming in. Great. All right. Well, while you're joining, first things first, I'll just introduce myself. My name's Troy. I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. And I'm so excited to be welcoming you all back to another NSWOC WOCC Institute Continuing Education webinar. Today's webinar is going to be on integrating silver dressings into the Antimicrobial Toolkit and tips for biofilm eradication. And with us today is Dr. Kevin Wu, who will introduce just briefly in a second. But before we get there, a couple little housekeeping items. Firstly, we're going to be having a Q&A portion at the end of this webinar. So please do use that Q&A tool that's in your Zoom toolbar. That'll make sure that Kevin and I behind the scenes here can answer them and make sure that you're not being missed out on. While you're doing this here, let's pull up the chat tool and let us know where you're tuning in from. So I'm tuning in from downtown Ottawa, from the unceded territory of the Algonquin and Anishinaabe. And it looks like we got some people from North York, we got Windsor, we've got Toronto, lots of Ontario. Hope to see people coming in from across the country too. All right, so without further ado, I am happy to introduce Kevin. Dr. Kevin Wu is a full professor at Queen's University at the Faculty of Health Sciences in Kingston, Ontario. He's also an adjunct research professor at Western University. He's also an affiliate scientist at the Institute for Education Research, or TIER, and the University Health Network. And he's known as an established Canadian researcher and educator in the fields of wound management and chronic disease management. He has published over 180 peer-reviewed papers and received national and international awards for his work. He also serves as chair of the Joint Research Ethics Board for West Park Health Centre and Toronto Grace Health Centre in Toronto. He's also a founding member and the past president of the Canadian Pressure Injury Advisory Panel and maintains an active clinical role in wound care. So without further ado, I'm happy to pass over the microphone and the slides to you, Dr. Wu. Thank you so much.
Thank you so much, Troy, for such a kind introduction. And thank you so much for inviting me to participate in this webinar tonight. So this is my disclosure slide, and all the opinions belong to me. Just really my perspective on wound care and perspective on the use of silver dressing. It's an interesting topic because I thought that we have talked a lot about silver dressings already, but I think I've been told that there's still a lot of confusion surrounding how to use silver, what are differences across different types of silver dressing. So I think there's still a need in terms of coming back to appraise the role of silver in treatment of chronic wounds, particularly the variety of strategies and how silver is part of this toolkit to eradicate biofilm or manage biofilm. And I'll spend a bit more time to talk about the unique properties of nanocrystalline silver. And of course, there will be some case studies and some scenarios looking at how we use nanocrystalline silver in a variety of wound types. Not a big surprise in terms of the conceptualization, the paradigm to describe bacterial growth. And this is the diagram that I extract from the International Wound Infection Institute, and this is the best practice recommendation published in 2022. And infection is defined as invasion of the body with microorganisms, whether it's fungus, virus, bacteria, and that had the response evoked by the invasion of those bacteria that we can recognize in terms of the signs and symptoms. And of course, one of the major things that we're concerned about is the impact on wound healing. And as you can see, the description of this continuum from contamination, colonization, local infection, spreading infection to systemic infection. So implicated across this continuum of infection pathway is the biofilm, the presence of biofilm that perpetuate and drive infection and drive chronic wounds more chronic, right? And that's why, chronic wound may be a chronic infection issue that we need to address the biofilm. We need to think about how to address infection. So let's start with the first polling question, just to make sure that that we all engaged in this webinar, right? What is the key challenge that you face with addressing biofilm or treating wound infection? We're trying to force you to just choose one, the key challenge. So not, I'm sure that there's a lot of items here that will resonate with you, but we just want you to choose one key thing. Let's see. I think we're going to give you a few seconds to make a choice. Is it because you're unclear about step-up, step-down therapy, uncertain about antimicrobial dressings and the risk for developing for people at risk of developing infection, concerned about cytotoxicity, too expensive, the evidence on eradication of infection, and unclear about, what is eradication of biofilm versus treating infection?
We've got about 50% participation now, if we're okay with that.
Sure. In the interest of time, this is a warm-up exercise. Hopefully, we'll have more responses in the future, in the next few questions. Okay, that's interesting. Unclear about step-up, step-down therapy. So let me explain that a little better for you. So this is what we call the step-down, step-up wound care approach, and initially promoted by a panel of international experts in wound care. The message is we need to be aggressive at the beginning when we're approaching chronic wounds. That may include, you can see the time frame, the first few days when you have a wound, when you have a chronic wound coming to clinic. Think about aggressive debridement or ongoing debridement, the use of early introduction of antimicrobials, because one of the major reasons why chronic wounds become so chronic is because of infection. Despite whether there may be indicators or signs and assessment, think about the patients who are at risk, think about individuals that, with wounds that have a lot of bacterial burden that need to be addressed right away. And then, of course, part of it is to look at wound bed preparation, managing the risk factors, and identifying the etiology and treat some of those correctable factors. And then we can step down gradually as the wound continues to improve over time, de-escalating our treatment. We may not need to debride so often. We may actually transition from the antimicrobial dressings to more inert material for local wound care. And then at some point, when the wound healing is stalled, then you might want to step up again. And so I think it's a kind of very elegant paradigm to describe the fluidity of how we approach wound care, and we need to exercise our judgment to think about as aggressive as possible in terms of our treatment modalities. And that's why, sometimes we say, well, there's no infection. Let's avoid using antimicrobial dressings. My comment is, well, perhaps we need to be more aggressive at the beginning, and we can prevent and actually accelerate the healing process at early stage, because once it will become chronic, it becomes more difficult to treat. Now, another question for you. Thinking about the implication for biofilm, what is the primary agent or tool that you use to target biofilm? Is it surfactant type dressings or cleansers, iodine-based dressings, silver dressings, chlorhexidine-based dressings and cleansers, hydrogen peroxide as a cleanser, a sodium hypochlorite solution, in other words, statin solution? Let's see. Cast your vote. People must be tired. The finger is getting tired.
Alrighty, we've got about 100 participants now.
Oh, how about
I'll
that?
show you these. And there you go.
Very interesting. So we have a lot of people have chosen iodine-based and silver dressings, and there's some people looking at surfactants and sodium hypochlorite. And I think I just wanted to have a quick few comments about some of the solutions, some of the choices here. We don't recommend hydrogen peroxide anymore, just because of the corrosiveness of the material that can actually damage the fragile granulation tissue. Chlorhexidine cleanser, there's quite a bit of debate, and it's not the best type of agent for eliminating a variety of pathogens. We use Claxin primarily for, resistant bacteria like MRSA because it's Staph aureus. So the effectiveness of chlorhexidine on other types of bacteria remain kind of a little bit equivocal. Surfactant, I think, is a good cleansing agent, but I don't think it's a good anti-biofilm agent per se, because it really can, get into the biofilm and address the bacteria inside the biofilm. And I have number 6, sodium hypochlorite solution, because there's been a lot of confusion about what is hypochlorite versus hypochlorite. So they're very, very different. And so that's why there's a Brachydican solution, which is a bleach with a very high pH. And again, because of the pH level, you actually get very little effective anti-infective agent. And in fact, it can be very damaging to the wound surface. So I would tend to agree with you thinking about iodine particularly, and also silver dressings. And I'll come back to talk about how those two different types of material and categories of dressings can help us as part of this toolkit approach to address biofilm and wound infection problem. But I want to show you this this diagram indicating that yes, maybe one of the important thing when we think about biofilm-based wound management is debridement and cleaning the wound mechanically, sharp debridement, and removing, disturbing the wound surface to disturb the biofilm structure. But the important part is the continued use and judicious use of silver or iodine dressing. It's very important to eliminate and keep the persistent cells under control, so you don't have the biofilm regrowing and proliferate again, and creating sort of and sort of at the level before the initial challenge. So I think that's an important message. That's why I think silver dressing is so important for high-risk individuals, and especially after you have done your debridement or someone has done the debridement. So think about that you have not eliminated all the persistent cells. Just, I think, one of the analogy I sometimes think about, it's just like, when you're using radiation. Yes, you might be able to eliminate and attack the visible growth, but there's still a lot of cancer cells that may be floating around. That's why we always follow with chemotherapy, to ensure that we just eliminate everything that may not be visible to our eyes or visible by radiologists, by radiology technologies. So the same kind of approach is, yes, you can remove all the devitalized tissue, remove biofilm and scrape them off, but there's always some of those persistent cells that can stay in the wound environment. So when we approach wound infection problem, I think I just want to highlight a few key things on wound cleansing. There are a variety of international consensus documents and statements about wound cleansing, and summarize them into a couple of slides here. So by dribbling a few drops of fluid, saline or tap water, whatever it is, it's not really wound cleansing. You're just moistening the wound. So there are other techniques involved. You can soak a gauze with antiseptics, so you can use as a compress. You can swab and swipe the wound. And actually, one of the systematic review by Aaron Rahathy, and she sort of identified that swabbing and scrubbing may be painful for individuals and may increase the risk by forcing the bacteria to get into a deeper compartment. So something to think about when you're aggressively scrubbing the wound surface. So more popular and more general approach to cleansing the wound is using mechanical irrigation at a force of 4 to 15 psi pound per square inch. And this is a place where we think about potentially integrating surfactant material along with irrigation to facilitate the removal of debris and surface bacteria. And I think there's some literature indicating that antimicrobial cleansers may also have a place especially when they're able to produce and facilitate oxidative debridement property. But the important thing about the consensus is the adequate use of solution, the amount of solution, the volume of solution that should be used. So recommending at 50 to 100 cc per centimeter of wound length. So in other words, if you have about a 5 by 5 centimeter wound, which is not that big, right? About yay size, you need about half a liter of fluid, 500 cc's of fluid to irrigate that wound. Yeah, I don't think we're using that much irrigation and on a regular basis. So something to think about reflecting on your practice. And also important part is to use a solution that is warm in the room temperature, that is appropriate, so you're not going to cause any damage to the keratinocytes. Another important message is the peri-wound skin hygiene, cleaning the peri-wound skin. And I think in some cases, it's more than just in peri-wound. In this individual with venous leg disease, you can see the lipodermatous sclerosis resulting in woody changes of the skin with a lot of scaling going on. And we see this with chronic venous disease. We see this people with, after they have acute episode of infection with the swelling and then with the stretching of the skin. Once the inflammation has subsided, you get a lot of scale going on the surface. So, and definitely it's very important to look at peri-wound and that may involve the entire leg to remove all the devitalized tissue, the hyperkeratotic area where those skin is going to harbor the bacteria, the pathogen, the fungus, and potentially can even affect the effectiveness of compression therapy if you have too much scale going on the leg. So I just want to show you the importance of the skin hygiene component. So there are a number of phenotypical changes along with chronic wounds that render individuals or render that wound more at risk for developing infection problem. You can see that there's impaired epithelialization, impaired keratinocyte movements, the ability to move to the center of the wound to facilitate wound closure, reduce in the immune cells and the ability to fight off infection and fight bacteria, also decrease in the angiogenesis. So I think there are a number of factors that can put people at risk for developing local wound infection. And once you have a wound that you're concerned about infection, we have developed this pathway looking at evaluating signs and symptoms and associated with infection. We divide infection into superficial or covert infection, biofilm related versus the overt deep spreading infection. I'm sure that you can have access to this pathway through a variety of websites. If not, I'm sure that we can share that with you. I just want to really emphasize, try to re-emphasize the importance of looking at the wound type, the wound tissue type. I think Chris Murphy had introduced the term granulitis to describe inflammation of granulation tissue, because the signs associated with wound infection could be so subtle that you may recognize that, oh yeah, that's granulation tissue, the wound is healing, it's fine, it's perfect. We're doing, everything is on the right track. But when you look closely, comparing what we call inflamed granulation tissue with healthy granulation tissue, they have very different presentation and quality. You can see that there may be different color, maybe more friable, and there may be buildup of gelatinous material on the surface. And you can see that on the, my cursor is not working on the slide here, but on the bottom left is a pilonitis. And you can see the granulation tissue inside, and the term that people have introduced is a pocketing. You can see pockets inside the granulating surface. And again, suggesting that there are sort of overgrowth of bacteria damaging the quality of granulation tissue. In fact, sometimes we just use a gauze to wipe off the area. along with it, the granulation tissue may just sort of the stringies that will come off from the wound bed as well. And that's why it's so important to think about using topical antimicrobial agents when you're dealing with local infection versus a combination of antibiotics and topical agents for spreading infection, recognizing that the area may have poor circulation, that despite the use of antibiotics, it might still take some time for the antibiotic agent to percolate to the local wound environment to address local burden of bacteria. And that's why I like that there's sort of like a sandwich approach with topical agents and also in combination with systemic agents for spreading and deep infection. So recognizing that a lot of people would select silver dressing for the management of wound infection or biofilm problem, what is the most relevant factor that you consider when selecting a silver dressing? There are a few choices. Is it about the silver concentration that we aim for 1 to 5 ppm? Bacteriostatic property of the dressing, broad spectrum antimicrobial activity, or ability to maintain a moist wound environment without causing trauma to the tissue? Less choices for you this time, 4 choices. Let's see. And I'll come back to explain some of the concepts for each individual choice here.
All right, we'll end it there. We had well over 100 participants, and you should be able to see the results in front of you now.
Okay, very good. Excellent. So I'm glad that not many people have chosen the first two, because I don't like the first two choices either, and definitely want to have a very broad spectrum antimicrobial property at the same time have the ability to manage a moist wound environment. So let's come back to talk about ppm, parts per million. I think the easier way to explain it is, we can all appreciate the concept of percentage. 1% is 1 part per 100. So if you have 1,000 people, 10% is 100, right? I'm doing my math. Hopefully my math is correct. So parts per million is 1 part per million. So instead of 100 being the denominator, so now the denominator is 1,000,000. So it's a very minuscule amount of substance, and we're talking about diluted per million. So that's a very important concept when we think about the concentration. And there's a lot of debate about what's the ideal optimal ppm, parts per million of silver, should be in a dressing to exert a anti-infective effect. And stay tuned for 1 second, because I want to clarify the two concepts, bacteriostatic versus bactericidal, that you can see the graph here, bacteriostatic in the green curve. You're basically not really reducing the bacterial count, the number of bacteria present in the wound environment. You may be able to inhibit the growth. So it's not really ideal in a situation when you're trying to address the wound infection or reduce the risk for infection. Versus bactericidal, you can see the red curve here. There's a significant precipitous drop in the bacterial count, indicating that we're actually eliminating the bacteria. So yes, it's a desirable property, and important to ask the question when you're evaluating certain antimicrobial agents or new agents that has anti-infective effect, because the more the longer the bacteria can stay in the same place, and the more likely they're going to exchange genetic material, developing resistance and build virulence against the agent. So the parts per million question, coming back to that. So, and that's why we ideally want to have a certain amount of silver in a dressing to produce this bactericidal effect. So it's not just bacteriostatic, because we know that it's important to fight infection with agent that is bactericidal. So for silver to be antimicrobial, has to be ionic, has to be ionized. So that's why with the Ag plus, the plus sign is the positive charge. It will bind to the negative charges on the cell wall, on the bacteria. And that's how they sort of attract each other, find each other, and inactivate the bacterial cell. And based on this interesting research published in 2019, and you can see the citations, there is an independent study. They look at a variety of different dressings with silver and try to ascertain the sweet spot, the right amount of bacteria to produce effective bactericidal effect without toxic effect. So it's interesting that they identify, based on their evaluation of the whole gamut of silver dressings, 30 to 40 ppm parts per million silver is the ideal concentration that is needed to be the most effective, to have the most effective bactericidal effect in the wound environment. And if you have too much, more than 60 to 90 range, then you run into a little risk of the toxic effect, the toxic concentration that can inhibit fibroblast activity and growth. And especially with certain type of resistant bacteria, and you can see the comparison between bacteria in general versus MRSA, sort of multi-drug resistant type bacteria, then it's more desirable to have a higher concentration of silver. And how silver works is summarized on this diagram here. It can bind to the cell membrane, those little red dots representing silver molecule, and it can bind to the silver, it can bind to DNA structure, producing this oxidative stress, the reactive oxygen species inside the cell that can directly kill the bacteria because it's so potent as an antimicrobial agent that is produced by the body. And also, it can also inactivate some of the enzymes and protein inside the bacteria. And that's why resistance is extremely rare with the use of silver, because it may need multiple mutations to develop resistance, given the multi-angle approach that silver would use to inactivate bacteria. So after all that conversations, let's see if there's some buy-in here. All silver containing antimicrobial dressings are the same. Let's see. So you can choose very untrue to very true, or you can stay neutral. So there are 7 choices. And
yeah, lots of good participation. Just maybe 3 more seconds. There we go. All right, you should see the results now in front of you.
Results, very good and interesting. So most of you would say that very untrue to somewhat untrue. Yeah, I think that's where I'm leaning. So there are a variety of silver dressings out there, and with different types of molecules as well. We'll focus a little more on the nanocrystalline silver technology. In a lot of the dressings that we have encountered, they have silver salt, and I think in the past people even have used elemental silver and colloidal silver. And when I first heard about silver dressing, and people have told me stories about people in, I think, Mexico, and they would have colloidal silver drink with silver suspend in the elemental silver suspended in drink, so they can drink it. well, no wonder people develop kidney failures and all the problems. But anyway, yeah, those type of agents, colloidal silver, elemental silver, because it's non-ionic silver, they don't really have a very good antimicrobial effect. And we'll come back to talk a little more about the difference between nanocrystalline silver and silver salt. And also there are different function in different form of silver dressings as well. It can be silver can be a coated material on the dressing itself, or it may be integrated in the structure. And I think I use the term a passive versus active antimicrobial action, meaning that some dressings will be able to deliver silver into the wound surface, into the wound environment to interact with the biofilm, interact with bacteria, versus some other dressings maybe more passive. They wick away the fluid, along with it all the bacteria, and the bacteria got eliminated and inactivated inside the dressing in the presence of silver and other molecules that have antimicrobial effects. And we have addressed the bacteriostatic versus bactericidal effects already, and definitely there's a desirable range of silver contents concentration that is required to exert a bactericidal effect. So just to illustrate this point, all silver is the same. We're all familiar with material like flamazine, the silver sulfadiazine cream. And it's very popular for a while, especially among burn care for burn patients. It's very economical, very cheap. It can be spread in big areas. And in fact, it has a very, 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 very high concentration of silver, up to about 3,000 parts per million of silver. And that's why the point too is higher concentration silver is not always the best agent, because what you can see is with this agent, it will just, there's no locking mechanism to produce a sustained release mechanism. So all the silver is just immediately released into the wound environment within the first 30 minutes. And that would explain the very toxic effect on the wound. And a lot of times we're concerned about the damage that can produce a pseudo eschar that's sort of like this sort of a yellowish material, the fibrinous material on the wound surface. It can also promote maceration and subsequently retard and slow down the epithelialization process. So when you look at all the Cochrane reviews, and one of the things I always mention is, SSD, silver sulfadiazine cream, is probably the culprit for diluting the treatment effect for using silver in the treatment of chronic wounds, because you can see that it has a lot of negative effect on wound environment. And so in comparison, so what about all the other silver products? Yes, flamazine on the bottom, 3,000 parts per million silver, and very, very toxic effect, versus on top, Acticoat, the nanocrystalline silver, you have about 70 to 100 parts per million. So versus others, why I want to highlight others? Because there are some existing products out there with lower concentration of silver, but based on some of the systematic reviews of the literature and evaluation that confirm that we do need perhaps a high range of concentration in order to address some very stubborn, very recalcitrant, very resistant type bacteria. So in other words, not all silver dressings are the same. I like this this quote: "Believing in everything at the same time is the same as not believing in anything at all." So otherwise, be very critical and be very judicious about the choice of silver based on the patient, based on the wound that you're encountering. So just want to sort of dispel some of the misconception and clarify some of the key messaging around nanocrystalline silver. It's a nanoparticle. And basically, my analogy, and this is a nice little picture to show you, they're in the clusters form. And all the silver molecules are stuck together in this sphere, in this ball of silver molecule. With interaction of wound fluid, it activates the ionic mechanism, the ionization mechanism. So the cluster will release ionic silver into the wound environment. So the idea is now you have a bigger surface area of nanoparticles that can interact with the wound environment and also with the sustained release mechanism as well. So if you can look at this slide, you can see those molecules releasing the nanocrystalline silver, releasing ionic silver, and each molecule has a high surface area that can interact with the negative charges on the wound surface. And once entered into the wound environment, it can interact with the cell wall, interact with the DNA, mitochondria, and all the other organelles inside the bacteria itself, inactivating them. And that's why, it's a very effective agent to kill bacteria, especially when they're floating around the sessile form of bacteria. And there's been quite a bit of publications on the broad spectrum activity of nanocrystalline silver against gram-positive anaerobes and fungal bacteria and fungal agents. And I want to highlight this slide because I think as we continue to learn more about wound infection, I think there's a lot of resistance and a lot of bacteria agents that we need to pay attention to, especially with pressure ulcer, pressure injury, because of the environment itself. It's such an ideal place, a reservoir for multi-pathogens, especially gram-positive and anaerobes, if you have a lot of undermining and tunneling, because in those spaces, you don't have a lot of oxygen, right? Also, that we recognize that a lot of wounds can have what we call the opportunistic microorganisms, such as Klebsiella. So those are kind of interesting bacteria because they usually use oxygen, but when there's not enough oxygen, they can still survive. And then they switch the sort of a survival strategy to become more anaerobic. So those are very smart type bacteria, and we have seen literature talking about Klebsiella is on the rise in some of those pressure injury patients. And of course, some of the multi-drug resistant bacteria with extended spectrum beta-lactamases that we need to that can sort of resist the common type of antibiotic agents that we use, and Pseudomonas. And there's a lot of mechanism that we understand Pseudomonas can develop to not a resistance mechanism per se, but they become more tolerant to antimicrobial agents. They could have a efflux pump develop, so pumping out all the silver out of the bacteria. They can reduce intake, they can alter the enzyme shape, they can also reduce the receptor sites, so they're not going to be sticking to the silver, so they cannot be inactivated by the silver. So it's not true resistance, but this may be a tolerance problem. And that's why my thinking about when selecting for silver is to ensure that you remember the step down, step up. Be very aggressive at the beginning. Use a high concentration silver material so we can hit the nail right on the head at the beginning, instead of kind of fooling around and not really getting the nail into the area where we want it to be. So I think that's kind of my take on why we need to use a high concentration silver for some of the stubborn, for some of the bacteria that have a very high tendency to develop tolerance and develop problems in chronic wound environment. In addition to the antimicrobial property, nanocrystalline silver can also produce Ag0, which has an anti-inflammatory property. I think this is a study and systematic review looking at the and validating the anti-inflammatory action of silver nanoparticles. So it is there, and it's not that is irrefutable. So just a few case studies before closing, and you can see that this is a pressure injury in the ischial area. And I have chosen the Actico flax in the ribbon form. For people not familiar with this dressing, you can see the structure. It's very thin. It has a high tensile strength, and it's fenestrated. It allows food get through, and if you're using a transfer dressing or using absorbent dressing on top, all the fluid can still get into the absorbent layer in the foam dressing itself. And the other property I really like about flax material is the softness, and that's why I think they call it flax, because it's so flexible that allows the material to get into the wound without causing a lot of trauma locally into the wound. Because imagine if you're sitting on a lump of gauze, a lump of ribbon material, the damage that potentially induce on the fragile granulation tissue. So you can see that after a couple of weeks, there's a good granulating layer after the introduction of nanocrystalline silver. So because of the interesting property of the fenestration on particularly with Actico flax, you can see this individual with a dehisced amputated site, and we'll clean it up, remove all the non-viable tissue, and now we have a wound that waiting to be stepped up again. We want to ensure that we being very diligent with introducing the best measure we can take and we can use to promote wound healing. So we apply the silver dressing on the wound and the Actico flax, and then cover it with a negative pressure wound therapy single-use dressing. And you can see the outcome in 3 weeks. We're able to reduce the size of this wound quite significantly. Otherwise, who knows, this individual may require a revision of the residual limb. So this is one of the pictures indicating or showcasing how the flax material can be applied under negative pressure wound therapy. And it's because of the fenestration, because of the permeability of the dressing itself. And this is another patient. It's actually not a Canadian patient, and this is a colleague that I worked with in Mexico. And he had never heard about Actico before, and I was doing a presentation last year, and I brought along with me a few dressings to sort of do some demonstration. And then I have some leftover. I said, well, he showed me this patient case. I said, well, that looks like something more effective that need to be used instead of using just the dry gauze material. So so I introduced to him the Actico dressing. Oops, I think it may have disappeared with the Actico applied to the wound. And after even just 2 weeks, you can see the reduction in wound size. And he emailed me immediately, and he was so impressed by the outcome. And of course, I think there are challenges in that local environment in terms of the resources available to the jurisdiction. And I think we're in a very privileged place where we have a number of choices, and that's why we try to choose the best agent we can use for our patients. But if this is more available and accessible in other countries, this could be the amazing outcome that clinicians can achieve and saving limbs and saving legs. This is another interesting patient. Patient with initially what we thought was a deep tissue injury, and in the ICU in the intensive care unit. And the nurses didn't think too much about, because you look like a deep tissue injury. What else can we do, right? So, and of course, deep tissue injury is this maroon purplish discoloration, usually develop uh, after 24 hours of a pressure event. So if that happen less than 24 hours, then usually it's not so much about deep tissue injury related. And that's the conversation that people tend to have about skin failure. I was privileged to be part of a meeting with the NPIP talking about they're trying to define and conceptualize skin failure, and there will be a best practice documentation going to be published by the panel redescribing some of the key concepts. I think what I got out of that meeting is that it's not just about people who are dying, but a lot of times it could be in the critical care patients, and when they're receiving vasoactive substances like epinephrine, Levophed, and definitely has a direct impact on the local perfusion. That recognizing that skin is the biggest organ of the body. When there's not enough perfusion and there's multi-system failure, multi-organ failure, the skin will fail along with it as well. So usually that kind of separate out between skin failure versus deep tissue injury, because we look at those risk factors in a time frame that develop some of those presentations. And in fact, just to tease interest in this area, that there has been some proposal about developing ICD coding for skin failure along with pressure injuries. So instead of calling pressure injuries as pressure injuries that are not preventable, and then perhaps there's a need to look at coding unpreventable, unavoidable skin damage, and we call it the skin failure that can be classified as acute, chronic, or end-of-life related. But anyway, I think the conversation will continue, and as the research continue to advance, and we have a better understanding of some of the risk factors with age, pharmacological related dying process, and then the pathophysiology involving hypoxia, inflammation, and the whole cascade event along with hypoxic damage, and then resulting in physical, immunological, and microbial changes. So, but anyway, that's why that teased my interest in terms of looking at whether this is really a deep tissue injury versus a skin failure picture. But we removed some of the necrotic tissue, resulting in a very deep wound, and using the nanocrystalline type dressing, you can see that within the 3 weeks, and we again see a significant improvement in granulation tissue. I mean, there's still an area that is quite concerning in the friability of tissue. Usually we use the antimicrobial dressing for 2 weeks, a 2-week challenge, a 2-week rule of thumb. But in this case, we continue with the dressing, and we see a reduction in the wound fluid odor and continue to improve over time in terms of the sizing and the quality of granulation tissue. So I think, yeah. So in my summary for this few different scenarios is really looking at selecting the right agent. There's a need for using silver, particularly for high-risk individuals, for deep wound infection, particularly for a lot of bacterial burden, for very stubborn type of bacteria. And if people have still raising question about cytotoxicity, I hope this study can really put that to a little bit of to settle that debate a little bit, because based on the variety of studies they have reviewed in this publication, there are 5 different studies that they evaluated cytotoxicity in terms of the blood level, in terms of the cell activities, histological evaluation. Yes, you can, in some cases, you can detect silver in the blood with more than 0.01 parts per million, really small amount of silver. But in terms of the histological, in terms of actual cytotoxicity, there's no indication, there's no clinical symptoms associated with wound damage caused by the use of introduction of silver dressing as an indication for cytotoxicity. So yeah, think about good wound hygiene. Think about step down, step up. Be very aggressive at the beginning, so we can reduce colonization, reduce the chance of developing infection. Think about wounds at risk. Introduce antimicrobial therapy at the earliest stage when you know those wounds are not improving, and then continue to use the antimicrobial for about 14 days and evaluate. So let's do a little temperature check again. Coming back to this question, all silver containing antimicrobial dressings are the same. Do you agree or disagree? Let's see. What do we have, Troy?
We've got quite a few showing. You can see the results now there in front of
Oh
you.
my gosh, we have moved the dial. So anyway, I think that at least that's our current understanding and based on the evidence. So hopefully this is helpful to you. And I think the takeaway messages here are the silver dressings for the treatment and prevention of wound infection. Think about early introduction of antimicrobials. Of course, holistic assessment is so vital to be part of that exercise of deciding when and how to introduce antimicrobials. Not all silver dressings are the same, and I encourage you to think about using this IM pathway in practice. And that is a evaluation code, a QR code, and I encourage you to provide feedback to us. And I hope that this is clear and helpful with your practice. Happy to answer any questions and comments. If you feel free to voice your disagreement too.
Perfect. Well, thank you so much for going through that and some great case studies there. That was really fantastic. We've got tons of great questions here, so we'll see how many we can get to, but we'll try to go through all of them. I think what we'll do is maybe go from towards the beginning of the presentation. We'll work our way back to see if we can kind of learn as we go. Would you be able to just overview again? We were talking about the different types of cleansers at the very beginning. Did you want to just touch on the use of hypochlorous acid as a cleanser to manage biofilm?
Sure. I mean, this is another talk by itself about the variety of cleansers and what is hypochlorite and versus hypochlorous acid. So it's really about the pH level. It's the determinant factor. And we're all familiar with bleach, which is hypochlorite, in a very high pH level, very corrosive. You use it to clean toilet, you use it to wipe things, and but it's such a high pH, and in fact, because of the high pH, it can be very damaging to granulation tissue. And because of the high pH, the sodium chloride is bound to each other, and there's a very dissociation for the chloride molecule to be effective agent to kill bacteria. And that's why people have manufactured and commercialized hypochlorous acid, which has a lower pH and allow the dissociation curve to be shifted to the left and making some of those antimicrobial agents more available to the wound environment. So let's keep it at a simple level for now. I'm sure that in the future there may be another conversation that people can present about what the differences are.
Absolutely. Well, thank you for touching on it anyways there. We really appreciate it. Let's go to this question here. One person was asking about how we can avoid transferring bacteria from the peri-wound into the wound during irrigation. So again, going back to the stuff we were talking about mostly at the beginning.
Yeah, I think that's an excellent question. And I think the technique maybe is slightly different. I don't think I would use irrigation in peri-wound skin because you don't really have a lot of fragile granulation tissue that you would concern about, with the scrubbing, with the wiping technique. So irrigation it's recommended for the wound surface in order to protect the tissue with the PSI of 4 to 15. That seemed to be the right amount of pressure. And then I'll just sort of do after the irrigation, then I'll do the wiping and do the scrubbing in the peri-wound skin to clean the wound. So I think that seemed to be able to avoid cross-contamination. But welcome to hear your thoughts too.
Perfect. Well, thank you for touching on it. We've got lots of great questions here, so thank you for continuing to send in there. One was just about whether the recording will be made available, so I'll get to that at the end, but we will be recording this and it will be available after the fact too. And for those asking, you will be receiving a certificate of attendance as well. Going back over to the topic here, one person was saying that they encourage patients with venous leg ulcers to remove their dressings and compression wraps and shower at home if they have safe water. And that sometimes that happens with the scale removal. And that's going back to the cases and the photos you're showing at the beginning. What are your thoughts on that approach?
Absolutely. I think there's nothing wrong with showering with clean water, as long as the water is running. I mean, it doesn't have to be venous lake ulcer. A lot of surgical patients, we recommend them to do showering as well, providing that there's no internal visceral organs exposed, providing that it's running water, it's clean water, and also providing that the individual is not immunocompromised, have no other risk factors that can put them at risk. So then in general, whether it is a diabetic foot ulcer, venous leg ulcer, I don't think there's any clear evidence to say showering is contraindicated.
Okay, no problem. Thanks for touching on that. Next, we're looking about toxicity here. If we're saying that toxicity happens around 60 parts per million, do we still use 60.5 ppm for MRSA, or do you use a lower dose with something else?
Yeah, excellent. Thank you so much for pointing it out. I think the key message is depends on I mean, of course, all the studies reported in the literature depends on the type of bacteria being evaluated. And now we actually see more resistant bacteria. We see more diverse type of bacteria. And I think the key message is a high concentration is needed compared to is needed for resistant type bacteria, MRSA 60.5 versus some of the Staph aureus, maybe 5 to 10 may be good enough. And when we're dealing with even more resistant, more sort of all this opportunistic type bacteria, Pseudomonas, very stubborn Pseudomonas, my own opinion is we might need something even higher concentration, 60, 70 parts per million, 90 parts per million in order to eliminate all the bacteria or, do a better job to control the local burden.
Okay, well, thank you for touching. I see we're getting closer to our hour mark. So see if I can combine some of these questions to get to them together. We're going to be moving on here to, sorry about that. Let's go with this one here. How often do you recommend changing silver dressing? Some clients are only seen twice a week. So what would be your recommendation there?
Excellent question. That's why, in ideal world, well, not in ideal world, I mean, persistently, I use a sustained release type silver, not something that's to dump the silver right away, like the flamazine type material. Now, the sort of cheeky answer to that question is, it all depends. I think it really depends on the amount of exudate produced. The more exudate produced from the wound, the more silver releasing mechanism is being activated, producing those ionic silver. So it's like it's like a bank, right, for the nanocrystalline molecules. So you have fluid, you activate the release, and the more fluid, faster release, more release mechanism. So if you have a highly exudated wound, lots of wound fluid, then you might want to change it more frequently because by the end of 3 to 4 days, well, all the silver molecules have been released. Versus for a less exudated wound, sometimes we might be even able to get away with every 7 days change. And there are, silver dressings, the Actico 7 days change, 7-day duration. So in other words, think about type of wound, think about the risk, think about the wound fluid.
Perfect. Well, thank you for touch on this. And we've got so many great questions here, and some are very specific, but really interesting ones nonetheless. I know we're getting to our hour mark here. So what we might have to do here is recommend that first to make sure you fill out the survey that's going to be coming up in your browser once you close here. Definitely scan the QR code you see on screen here, and you're going to get a follow-up email with the survey too. I know that Smith+Nephew is confirming that the SurveyMonkey link should be working. If you are receiving any issues, you can just send us an email. We'll make sure that we get you in touch with Smith+Nephew. But this won't be the last time we'll have some fantastic education on a similar topic like this. So we do encourage you to stay tuned for what other webinars we have coming up. So at this point, I just want to say thank you so much to Smith+Nephew for being able to help us have this education today. And of course, to Dr. Wu, this has been so great. And we can tell by all the reactions and all the great comments here that everyone really enjoyed it. So we hope to see you again in the future, whether on a webinar or in another capacity. It was great to have you on again tonight.
Thank you so much. Thank you, everyone.
Thanks, everyone. You'll all be receiving a certificate of attendance in the next day or so, so do stay tuned in your email. That's it from us at NSWOC, and happy Swan Week to everyone. That's our Skin Wellness Associate Nurses. We hope you participate with us for the rest of the week. Have a good night, everyone.